psychological factors have an important role in the onset, severity, exacerbation, or maintenance of the pain. And so we see multiple times in Pam's life where this pain has come up and been worse that we think corresponds with things that cause her eternal stress and conflict. Again, the symptoms are not intentionally produced, and she's not pretending. She truly believes that she's having physical symptoms from the car accident. Pam's pain is not better accounted for by a mood, anxiety, or psychotic disorder. So in our assessment, or in the therapist's assessment, the therapist was not able to find a separate mental health diagnosis. And the pain is causing significant distress and impairment in functioning. The pain makes you feel bad physically, and it does, get in the way of, things in her life, such as, her life, taking care of her children, and sometimes just going about, all the things she needs to do just on a daily basis. So the diagnosis on axis 1 is pain disorder associated with psychological factors, and it's chronic. We did not find any personality disorder or developmental delay. So there's no diagnosis on axis 2. On axis 3, there's no diagnosis because the doctors were not able to find anything medically wrong with Pam. For axis 4 problem, we said problems with the primary support group because she does have emotional difficulties with her husband. She finds that it's not a very close, not a very emotional relationship, and she often doesn't feel very supported by him in the roles in the relationship, with her having to be home and have all the responsibility for the care of 3 children, and him not wanting to listen to her about not wanting to move. And so the gap score we gave her 65 currently, and the highest in the last year. And now Meredith and Marisa are going to do a role play. Marisa is going to be Pam, and Meredith is going to be the therapist that's talking with Marisa about the results of the assessment.
We're going to stand because fewer chairs in the room. So.
Hi, Pam.
Hi.
How are you feeling today? So we finished your assessment. I gathered all of your information, and I know you met with the doctor and you did a pretty thorough history and examination. And based on all the information that we gathered, figured out that you meet the criteria for something that we call pain disorder.
Well, what does that mean?
That means that you are experiencing a lot of pain, and that it's not caused by a general medical condition. And instead it's related to psychological factors. But it's causing you a lot of distress, and it's impairing you in different areas of your life.
So you're saying my pain isn't real?
That's not what I'm saying at all. I believe your pain is very real, Pam. I know that you're in a lot of pain. And pain disorder is a real condition. Many other people have it. You're not alone. So part of what pain disorder is when I said psychological factors contribute to it. When during times of stress, or when there's transitions in your life, if you have to move, or things like that are happening, do you notice that your pain gets worse?
Well, yeah, I did that homework assignment that you gave me to log when my pain is, and it seems like I'm fighting with my husband, or the kids are getting on my nerves. It seems to flare up more. So I guess that makes sense.
Yeah. So the pain has been getting in the way of you taking care of your kids, and it's causing a lot of problems in your relationship. And I know that you've been searching for an answer for what's causing you this pain and what you can do about it for a long time.
Oh, yeah.
And it's been really frustrating. So let's consider this the first step on a new path. I think that we finally found the right diagnosis for you. And so we don't have to search anymore. We can start working on your treatment, which will set up some goals and start developing a plan for you to work on a life that's more pain-free and what you want it to be, what it looks like for you. Okay. Sound good?
Sounds good.
All right, thanks, ma'am.
All right, so I'm going to move into the treatment section of the presentation. And just a real quick recap on what Lynn and Meredith touched on already. But this is how a somatoform disorder patient, particularly Pam, would present into treatment. So first they would have a medical evaluation from a general practitioner or maybe a specialist. And once no physiological basis for the pain was found, they'd be referred to a pain clinic. From there, an interdisciplinary team would conduct an evaluation to see, again, if there is any physiological basis, if there is a medical condition, and then also look for psychological factors that could be contributing to the pain. From there, an appropriate somatoform disorder diagnosis would be assigned to the client, and then a treatment plan would be customized to meet the individual needs of the client. And so, steps 3 through 5 would really take place inside the pain clinic. And this is how Pam was treated as well. So looking at the interdisciplinary team, so in pain clinics there's medical doctors who are going to be there to assess and treat any medical conditions. They're going to have supportive medical staff, nurses, specialists. Psychiatrists would be present to evaluate, prescribe, manage medications. They would also be part of the diagnosis process, assessment and diagnosis process. And then social workers and psychologists would work together doing similar work, assessing, diagnosing, treating. The psychologist can also provide psychological testing if that's necessary or would be helpful. So Meyer and Weaver refer to 7 core treatment principles if you're treating any somatoform disorder patient. So the first one is really important. So suffering should be accepted as real. They really are experiencing the pain, as Meredith described earlier. So we want to avoid ever making them feel as though their pain isn't real, as we saw in the role play. We also want to have regularly scheduled visits for treatment, which avoids the production of a new disorder or maybe more severe pain to be able to be seen. After a thorough examination, obscure lab tests should be avoided. So this happens a lot where, and the tests can be very costly, it's time consuming for physicians and for the patients, so we really do want to avoid this once it's been determined that there really is no physiological basis. And the patients many times are going to be requesting these continued tests. So, also anti-anxiety or sleeping meds should seldom be prescribed. They can be addictive. So in general, it's recommended that they are avoided. We don't want to prescribe pain meds as needed. If they are prescribed, it would only be for very short, specific, discrete periods of time. Also, we want to get the clients moving psychologically, physically, socially as well. Rest is always considered counterproductive for somatoform disorder patients. And then we want to include the family so that we're really treating the system. All right, so I'm going to, this is the most exciting part of the whole presentation, is reviewing the evidence-based practice. So just initially, looking at somatoform disorder, it's a very challenging disorder for particularly the medical field. Allen and Wolfark report how professionals often believe it's one of the most difficult disorders to treat. The patients overuse healthcare services and derive little benefit. Patients are typically dissatisfied because there isn't a physiological basis for their pain, and so they don't understand what's going on. And also then physicians can be frustrated by the frequent complaints and dissatisfaction by the patients. So the medical field is really turning to mental health professionals to treat this, and it's been studied more rigorously recently, but there's still limited research out there in many areas.